Good evening, everybody, and thank you for joining us for our final session in wound care in general practice. Our presenter tonight is Sarah Ford. My name's Jenny Pearson, and I'm one of the education officers for the Primary Health Network. Just before we start, I'd like to acknowledge the traditional custodians of the land that we meet on tonight and pay respect to elders past, present, and emerging. There will be an evaluation will pop up at the end of the webinar tonight. It's a very quick one, so if you could just take 30 seconds to fill it out, we would appreciate it. There is a chat pane on the right-hand side of your screen, so if you have any questions, you can type them in there. Sarah will answer the questions at the end of the session, so please hang around for that. I'd like to thank Hartmans very much for sponsoring this series. It's been very popular. And of course, there's no expectation that you use Hartmans products. It's entirely up to you and your clinical judgment. I think that's all there is from me. So I'll hand you over to Sarah.
Thanks, Jenny. Right. Thank you and good evening. Welcome back to the last of the series of 3 educational webinars on wound care, which I hope you found informative and will help you in your clinical practice. Tonight, we're going to cover the main causes of leg ulcers. We'll again review assessment and understanding the underlying cause of a non-healing ulcer. We'll review the treatment options for diabetic, arterial, and venous ulcers. And finally, we'll look at compression bandaging and finishing with a quiz tonight, which will be a bit of fun and a bit of a recap. And then we'll have time for questions from you at the end. So to start with, we'll just look at a definition of a leg ulcer, and one that I liked is a defect in the skin below the level of the knee persisting for more than 6 weeks and showing no tendency to heal after 3 months or more, which is basically the same as for hard to heal wounds, where the patient's health is preventing the wound from healing. The main types of leg ulcers are arterial, diabetic, either neuropathic or neuroischemic, mixed etiology, which is a combination of both arterial and venous, which are really challenging, and finally the most common form, which are venous leg ulcers. But of course, there are many other causes of leg ulcers, and we always need to consider other possible causes when assessing the patient. These include neuropathy due to a loss of protective sensation, and as a result, people just aren't aware of they're doing any damage to themselves, and they can't feel anything from the damaging effects of the neuropathy. Vasculitis resulting from inflammation of the blood vessels, causing changes in the blood vessel walls, which restrict the blood flow, leading to organ and tissue damage. Malignancy, which is always something that should be considered if an ulcer just won't heal, or if there are unusual rapid changes to the ulcer. If this is the case, consider taking a biopsy to eliminate any possibility of malignant changes. And infection, of course, either bacterial or fungal infection can stop a wound from healing and lead to further breakdown. Lymphedema resulting from problems with the lymphatic drainage, which can lead to skin breakdown and the formation of an ulcer, and trauma or even an old injury of the ankle can impact the movement of the joint, which affects the calf muscle pump, leading to problems with venous return in the lower leg. So, according to a study by Graves and Zeng in 2014, estimates of the prevalence of venous leg ulcers range from 0.05% to 1% in the community setting. Diabetic foot ulcers estimate estimates range from 1.2% to 20.4% in the hospital settings and 0.02 to 10% in the community setting. And arterial insufficiency ulcers estimate as few as 0.01 in the community setting. Of course, that was in 2014, so things could have well changed since then. We all know the prevalence of diabetes has increased markedly over the last few years, so I wouldn't be surprised if those figures are well out of date now. But it is quite hard to find up-to-date prevalence data. The evidence also shows that 26 to 69% of venous leg ulcers have a 12-month recurrence rate. And recurrences have been reported up to 5 years after healing because people just won't wear their compression. The prevalence of venous leg ulcers increases with age, affecting up to 2% of the population in those over 80. In Western countries, about 1% of the healthcare budget is consumed by the management of leg ulceration. And somewhere in the world, sadly, every 20 seconds, a lower limb is amputated due to complications of diabetes. I've really laboured on about the importance of assessment during this webinar series, and I think it's more important than ever to understand the underlying problem that's causing leg ulcerations, as things can go so very badly if the etiology is not properly understood. A worst case scenario is if you have someone who has an ulcer and it's treated with compression, but there's an underlying level of arterial insufficiency. This can be the result, and it's a bandaging disaster. Always take a clinical history to identify factors to help understand the underlying cause of the ulcer. Conduct a clinical examination, including palpating the pedal pulses. Measure the ankle brachial pressure index, or ABPI, to get an initial understanding of what the arterial circulation is like. In some instances, particularly patients with diabetes or renal disease, the arteries may be calcified, and therefore a toe brachial pressure is read as digital arteries in the toes are less affected by calcification. Photoplasmography is a non-invasive test that measures the venous refilling time, giving a more accurate picture of the venous circulation. And finally, a duplex scan is another non-invasive test to help understand the anatomy and blood flow of the lower leg. Prior to taking an ABPI, the patient needs to lie down and rest for about 20 minutes. Ensure there's no constriction of the femoral artery by the clothing or positioning. The systolic pressure in both legs is read, followed by the pressure in both arms using a handheld Doppler probe. Cover any ulcer or break in the skin with cling wrap to protect the cuff. And divide the highest ankle systolic reading in each leg by the highest brachial reading in the arms. Normal ABPI is 1. However, 0.8 to 1.2 is considered a safe range to apply compression of 30 to 40 millimetres of mercury for the treatment of venous insufficiency. This MESI ABPI device will measure the ABPI in a much faster period of time, and more information is available through EBOS or Vital or Warner and Webster. So at the end of the presentation, if you're interested in some more information on this, the email address will be available for you to send in a request for that. These are the readings to help you identify the competency of the arterial flow in your patient's legs. Anything below 0.8 will indicate that they have a level of blockage in their arteries and are not suitable for compression. And of course, anything above 1.2 indicates that there may be calcification of the arteries and they need further investigation. This is a common problem with people who have diabetes. So any patients that you're assessing with diabetes, this should be considered. Now we're going to look at arterial ulcers. Here are some legs that clearly have a severe level of arterial disease. You can see the round cut-out ulcers clearly delineated and coated in sloughy tissue, the shiny hairless skin, the cyanotic toes, and if you were to touch these legs, they'd feel quite cool, I'm sure. This poor patient is probably in a lot of pain. When taking a history, some of the predisposing factors that indicate that this person is struggling with poor arterial circulation are advanced age, a history of arterial disease or arteriosclerosis, a history of diabetes or hypertension, and these patients often show signs of poor arterial circulation that may be things like shortness of breath from heavy smoking. They may not look very healthy. They may be overweight, or their fingers may look clubbed with thick woody nails. The clinical appearance, as I said earlier, are often shiny, fragile skin, hard, woody toenails, and you can see those toenails there look quite unhealthy. A hairless limb, because all the hair follicles have died from lack of oxygen. Pale or blue appearance of the skin and toes. The skin is very dry and cool to touch, and these ulcers are often exceedingly painful. And the patients often complain of the pain when they have their legs elevated in bed, which is relieved when they lower their legs over the end of the bed. These people also say they get pain when they're walking and have to stop and rest to get relief. This is known as intermittent claudication and is a sure sign there is an issue with their arterial circulation. You often hear that these poor people spend their nights sleeping in a chair as the pain wakes them, and then they can't keep their legs elevated, so they have to sit up with their legs over the end of the bed or down over the chair. Finally, another indicator is ghostly white legs on elevation, which is known as a Berger's test. This is where a simple test can help you to assess the adequacy of the arterial supply to the leg. With the patient supine, stand at the bottom of the bed and elevate the legs to an angle of 45 degrees and hold for 1 minute. Observe the colour of the feet, and if the limb becomes pale, take note at what angle this occurs. This is the Berger's angle. The pallor indicates ischemia of the legs, as you can see in this image. In a healthy individual, the entire leg should remain pink, even at 90 degrees. A Berger's angle of less than 20 degrees indicates severe limb ischemia. The ulcers themselves look punched out as if somebody's gone over the leg with a melon baller and scooped out large chunks of tissue on the toes or on the lower leg. They have non-viable tissue present at the base of the ulcer with little or no exudate, as there's just nothing getting down there, so there's not going to be any fluid at all. And the granulation tissue looks pale and unhealthy. The clinical management is, of course, a thorough assessment and sending the patient for investigations to help confirm the diagnosis and refer on for a vascular consult. In many cases, surgery is possible to relieve the blockage, but if not, then maintenance and protection of the wound will be required to ensure no further breakdown and avoid an amputation. However, we all know that sometimes amputations are necessary to save a patient's life. Use the wound bed preparation concept we discussed in the previous webinar to outline a treatment plan, looking at the whole person before looking at the hole in the person. Good skin and wound hygiene will help to improve the healing outcomes of the wound, and if delivered at every dressing change, will provide the best possible chance of wound healing. Address the identified needs of the wound by selecting the most suitable product to manage these needs. For example, HydroClean Plus will clean the wound bed using its rinsing, absorbing action to donate Ringer's solution to wash the wound and then absorb any exudate and loosen up any debris and bacteria sitting on the bottom of the wound bed. It's then absorbed up into the dressing where it is held by the superabsorbent polymers. This will debride the wound and reduce the pain on the wound bed, which is often very severe and means options for debridement can be limited. If the circulation precludes debridement, then protect the wound with a dressing such as Zecuvit plus silicone border or something just soft and padding that's going to provide protection and comfort for the patient. Don't apply any compression. Now, let's look at diabetic foot ulcers. And I'm sure you must all see quite a few of these in your practice. What can you see is wrong with this foot? Yes, it has an ulcer surrounded by callus, which has been cut away to give that white appearance around the ulcer. I'm guessing that as the callus built up, it created a pressure point, leading to the breakdown of tissue underneath it. And as it pressed against the bone, it damaged the tissue and and caused the ulcer. So when the patient went to the podiatrist and they cut away the callus, they found the ulcer lurking underneath. You can also see that the foot is very dry, resulting in the formation of cracks all over the plantar surface. As you can see, it's out of shape as the arch has collapsed. This can lead to new pressure points as the person's gait will change. This is a classic diabetic foot ulcer. There are two main causes of diabetic foot ulcers. Ulcer formation as a result of the loss of sensation, but still the foot has good adequate blood flow, and that's known as the neuropathic foot. Or ulcer formation as a result of both loss of protective sensation and loss of blood flow, known as the neuroischemic foot. To expand on this a bit, the diabetes impacts three main areas. Firstly, the arterial circulation. The constant high blood sugar levels cause the microcirculation to be impacted and therefore reduces the blood flow in the microsystem, which leads to tissue breakdown. It's slightly different from the peripheral vascular disease, which affects the major vessels. This affects the microvessels, which makes it a lot more difficult to treat as they can't stent these vessels like they can with the major vessels. Secondly, infection. Diabetes impacts the production of leukocytes, which impacts the person's ability to fight infection. And in addition, this possible loss of sensation leads to an inability to feel when an infection is brewing, which means the infection can well and truly take hold before the patient even realizes it. As a result of this, osteomyelitis is a common problem, as the infection is not picked up until it's down to the bone. Thirdly, neuropathy can be broken down into autonomic and peripheral neuropathy. The impact of the autonomic nervous system, of diabetes on the autonomic nervous system, leads to a reduction in the ability of the person to perspire, and therefore their feet become very dry and calloused. This leads to fissure formation as a result of cracks forming in the callus and then the risk of infection. They can also develop a reduced flare reaction due to the breakdown of the autonomic nervous system. The flare response is the redness indicated when an infection is present. Therefore, a mild redness may indicate a more compromised state, as they just can't show the damage that's being done by the bacteria. Peripheral neuropathy presents in two different forms: sensory, resulting in damage to the foot from lack of sensation, or motor, resulting in deformation of the foot from atrophy of the small muscles of the foot. It can lead to a complication called Charcot's foot, which is a collapse in the arch of the foot as a result of weakening of the bone, joint, and soft tissues of the foot or ankle. In its acute form, the foot becomes red and hot with bounding pulses and is often misdiagnosed as infection. As I mentioned earlier, using the wound bed preparation concept will help you to understand the problem so you can provide a solution based on the needs of the patient and their wound. By dividing the dressings by their actions into clean, absorb, hydrate, and protect, it makes it much simpler to identify which dressing to select for the needs of the wound. Of course, prevention is ideal. By ensuring you identify any risks such as loss of sensation, ischemic changes, or changes to the gait indicating muscle weakness, you can put preventative measures in place early to ensure the patient is protected and less likely to develop skin breakdowns. Regular podiatry appointments, wearing well-fitting shoes, and education of the patient and their family, as well as their carers, will help to ensure any issues are identified early and preventative measures put in place. I do understand, however, that this is not always so easy and there can be many social issues that can stand in the way of good care. There are resources available that can help to provide you with information on the latest best practice and evidence to support your care. And here you can see them on the screen. These are available from these websites, so that www.ewma.org, or the better one, I think, which has all of these guides, is www.woundsinternational.com. They certainly provide a lot of really good documentation on all aspects of wound management. The other place that can be really helpful is the Wounds Australia website. And the venous leg ulcer guidelines are a useful resource to better understand the prevention and management of venous ulcers, and that's available free to download from this website. The guidelines, however, are currently being updated and should be available soon, as these ones were written in 2011. And there's a flow chart that's also available on there to help you to treat and manage venous leg ulcers. And that's what we're going to talk about now. So venous leg ulcers, the most common ones of all. And by now you'll be very familiar with this image, which is, as you know, my favourite of all my woundy images. I think it tells 1,000 stories, that ulcer. These are the most common form of leg ulcers, and often the ones that take longest to heal or just keep on coming back. The risk factors for developing a venous ulcer are history of previous DVT or deep venous thrombosis, past fracture or damage to the anatomy of the leg or ankle, which reduces the movement of the ankle, a family history of varicose veins or venous disease, and multiple pregnancies or obesity. An effective calf muscle pump is an integral part of effective venous return. I hope I can get this to start working. Just let me get my mouse up there, and should start pumping. The calf muscle pump is a combination of actions. The movement of the ankle joint causing the expansion and contraction of the calf muscle, which when walking causes the pumping action of the walls of the vein, opening and closing the valves and preventing the backflow. If for any reason the calf muscle pump is not working properly, it'll lead to a chain reaction which will impact the venous circulation. So as I mentioned before, if you have damage to your ankle joint and you're not actively working your calf muscle pump by walking and moving that ankle joint, that can quickly lead to a build-up of fluid in the lower leg and damage to the tissues. Here on the left, you can see the flow of blood back from the lower foot up the leg, moving from the superficial veins to the deep veins via the perforating veins. So on the, if I can just get my mouse up here, you can see here, these are the superficial veins here, and then they go deep into the muscle via the perforating veins to the deep veins, which are surrounded by muscle. And in this healthy venous system, you can see the valves working effectively, opening and closing with the contraction of the muscles. So that is a healthy venous circulation. Over on the right-hand side, you can see the valves are not working properly. They're incompetent as a result of the saggy, baggy walls of the veins, leading to a build-up of pressure in the veins themselves, which leads to the leaching of fluid out into the surrounding tissues. That's abnormal venous circulation. So the pressure in the walls of the veins causes the fluid that is within the veins to leak out because of this high level of the pressure as a result of the ineffective calf muscle pump. And then to compound this, once the fluid leaks out into the tissues, the toxins in the fluid build up a fibrin coating or cuff on the outside of the vessels, making it harder for the fluid to be reabsorbed back into the circulation again. The toxins damage the tissues, reducing the oxygen, making them really hard and difficult to work effectively. So the tissues start to break down as a result of this lack of oxygenation. So this flowchart demonstrates the impact venous insufficiency has on the body. Failed valves, deep vein thrombosis, or pregnancy or obesity lead to the venous buildup of pressure or venous hypertension, which then leads to leakage of plasma via the engorged capillaries into the surrounding tissues, which then in turn leads to this edema, which sitting in the tissues has the ability to build up this fibrin cuff on the capillaries, preventing the fluid getting back into the circulation again. So the white cells are trapped within that within the tissues. This then leads to poor cellular respiration as a result of a lack of oxygen in the tissues and metabolic waste removal. So that's all that toxic fluid is just sitting in the tissues, and that damage leads to prolonged inflammatory stage, necrosis, delayed healing, and of course a cellular imbalance. And we talked last week about the damage having elevated MMPs or matrix metalloproteinases and other proteinases can have on the tissues. So it's just a nasty situation leading to tissue breakdown and ulcer formation. Some of the clinical signs of venous hypertension atrophy blanche, which is a white scarring that appears around the ulcer, which can be really painful. And it's just scarring as a result of the damage caused by this fluid sitting in the tissues. Venous hypertension, so the raised superficial veins that look tortured and distended. We have lipodermatosclerosis, which if you break that down, lipo meaning fat, dermato meaning dermis, and sclerosis meaning hardening. So hard woody tissue forming a band around the leg, causing that inverted champagne bottle appearance. And hemosiderin staining or hyperpigmentation, which is brown staining as a result of red corpuscles leaking out into the tissues and staining them. Swelling of the limb due to extra fluid in the tissues being unable to escape back into the venous or lymphatic circulation. And this can be a result of poor lymphatic drainage as well as poor venous return, and often is a combination of both. Venous eczema or dermatitis, all the fluid sitting in the tissues can be irritating and leads to itchiness and inflammation. This is often how the break in the skin starts as a result of scratching that irritated skin. These legs are often prone to cellulitis or infection as a result of bacteria which can easily enter the skin and multiply, presenting as angry, red skin which is irritated and painful around the ulcer. The actual ulcers themselves tend to be located in the lower leg, in the narrowest part of the leg where all the pressure is. The edges are irregular and the ulcers are shallow. They're often widespread and can even be circumferential. The tissue is mainly viable, but some slough can be present on the surface, and they often have high levels of exudate due to the edema present in the leg. But of course, the pulses, if they've got good arterial circulation, and this is truly just a venous ulcers, then the pulses should be palpable, unless they have so much edema that you can't actually feel them. Never underestimate how important it is to thoroughly wash and prepare the leg prior to applying compression. The skin integrity of the leg must be cared for and preserved to ensure the ulcer doesn't spread. Remove all the dry skin and hyperkeratosis, as this is where the bacteria can harbour and thrive. It also feels so nice for the patient to have their leg washed and really thoroughly cleaned. This is good wound hygiene in action, cleaning the wound and surrounding skin to remove any obstacles and help improve healing. Remember we talked last week about how we want beaches around the edge of the wound, not cliffs? Well, this is an exact example of where we want beaches, not cliffs, so the epidermal cells can easily migrate across that clean wound bed. Cover the skin in a suitable pH-neutral moisturiser to protect the leg from drying out prior to compression. Use this opportunity to measure and photograph the leg so you can accurately document the progress of the wound. Then apply a suitable dressing. As it'll be the compression that's doing all the heavy lifting here, all you really want over the wound is something to protect it and absorb the exudate. When compression is first applied, there may be a lot of exudate coming from the wound, so it may be necessary to change the dressing more often. I'll come back to that when I'm talking about bandaging solutions. Here are some of the dressing suggestions from Hartmann. Atropine silicone to prevent the bandage from adhering to the wound and allow the exudate to pass through, and Zejuvit Plus to absorb and hold the exudate away from the wound and surrounding skin. So you really just want a light covering over the wound to allow the exudate to pass through, whatever that might be, a wound contact layer of some description, and then something to absorb the exudate. Or you could use our all-in-one dressing Zejuvit Plus silicone without the border to protect the wound bed and absorb and hold the exudate under compression. I wouldn't use a dressing with a waterproof backing, such as a foam with a waterproof backing, as they rely on a level of breathability to manage the exudate. And with a padding bandage and then a compression bandage over the top, it'll reduce the breathability of the dressing. So under compression, stick to a dressing without a waterproof backing layer. Now I'm just going to touch on ulcers with mixed etiology. These are extremely challenging as they're a combination of poor arterial and venous circulation, and therefore compression can't be applied without compromising the already inadequate arterial circulation. It's important when managing these ulcers to understand first and foremost how compromised the arterial circulation is, and if the person can have any surgery to improve the perfusion. The amount of compression to be applied, if any, will be determined by how much arterial circulation they have. Sometimes light compression can be quite effective. Now we're going to look at compression therapy. As the circumference of our ankle is usually half that of the calf, the pressure applied when a bandage is wrapped around the leg will be twice as much as at the ankle than it is at the calf. This forces blood back up the leg through the venous system and back to the heart. Before applying compression, always ensure you have good understanding of the arterial circulation and the patient's cardiac output if they have a lot of edema. You don't want to be overloading the heart with a sudden increase in circulating blood volume. The person applying the bandage must be trained in the application of compression bandaging. And the bandage must be a compression bandage, not a retention bandage, or any bony prominences must be padded out to prevent any damage. And of course, the ankle circumference must be smaller than the calf circumference to achieve graduated compression. This may seem obvious, but there are many tree trunk legs where the ankle circumference is the same or even more than the calf. If this is the case, then pad out the calf to ensure it's larger than the ankle to get better graduation. This is not a good look. After application, tell the patient to watch out for discoloration of the toes, excessive pins and needles, a loss of sensation or increased levels of pain in the calf or the foot, and always listen to the patient when they say they're in pain. Of course, there are different types of compression and you need to understand how they work and when to use them. Full compression should provide between 30 and 50 millimeters of mercury compression at the ankle down to half that at the calf. Inelastic or short stretch, high stiffness bandages create a rigid cylinder around the leg. So when the calf muscle pump expands, it directs the force back into the leg, acting on the deep veins to reduce the edema. Therefore, this bandage is only effective when the patient is mobile. It's not effective on inactive patients as it's only working while they're walking. Elastic, long stretch, low stiffness bandages are more suitable for people who are less mobile, as they have a higher stretch fabric. They provide constant pressure predominantly to the superficial tissues from the outside, providing the extra bit of squeeze in the immobile patient. However, they should be taken off at night if there is any risk of any arterial disease. There are a number of two-layer compression systems available now, and Hartmann have a two-layer compression system, which is a combination of the two different types of compression, short and long stretch. So it's effective when the person is walking, but also provides that extra bit of squeeze when they're resting. Putabinder is an example of a short stretch compression bandage for people who are mobile and need compression. It provides up to 50 millimeters of mercury compression at the ankle and fluctuates down to 20 millimeters of mercury as the calf muscle expands and contracts, providing a massaging effect on the leg. It can be watched up to 20 times and is also useful if you want to reduce high levels of edema in the early stages of wearing compression. It can be changed daily, and while one is on, the other one can be in the wash. It makes a cost-effective solution in those early days of compression when there are lots of edema and the exudate is very high. So you need to change the dressing regularly and the bandage as well. Once the edema is settled down, then you can apply a bandage system, which will last for up to a week, like the two-layer system. Always apply an undercast padding layer under any compression bandage to protect the skin and pad out any bony prominences. This bandage, Lastideur Strong, is an elastic or high stretch bandage designed to compress when the patient is both active and resting. Therefore, the compression delivered when they're walking is less as it expands with the calf muscle like an elastic band. It should be removed at night when the patients have their legs elevated and need to be reapplied in the morning as soon as possible to reduce the amount of edema buildup. It can also be washed up to 20 times, but don't dry it in direct sunlight or it'll ruin the elastic fibres in the bandage. And of course, always apply undercast padding to the limb first to protect the leg and pad those bony prominences. FootaPro 2 is a bandaging system designed to provide both short and long stretch compression to the leg. It delivers up to 50 millimetres of mercury compression at the ankle, and it's working while the patient is walking as well as when they're resting. It's designed to stay on for up to a week, allowing the patient to get on with their lives. It's comfortable and cohesive to reduce slippage, and like all our compression bandages, it's latex-free. Light compression is sometimes ideal for patients who can't tolerate high levels of compression and need to have something that they can gradually build up to. L'Aster Light is an example of a light compression bandage that can be used effectively for these patients. It's better to have some compression than none at all. I also wanted to mention that those white anti-embolic stockings that people often come home with and use as compression stockings are only actually delivering 15 millimetres of compression at the ankle, and that's not adequate to provide good venous return. These stockings are designed to prevent DVTs when people are immobile and on bed rest following surgery in hospital. Excuse me. Modified compression can be useful for patients with mixed etiology. Light elastic bandages will provide a lower level of compression, 18 to 20 millimetres of mercury at the ankle, and are more easily tolerated for those who struggle with compression. Getting compression bandages off and on can be difficult for some people, particularly the elderly, and studies have shown that tubular bandages can be an effective method of applying some form of compression. However, as tubular bandages are not graduated, to achieve higher pressure at the ankle, there needs to be more layers in this area. So it's recommended that 3 layers of tubular bandage are used. Apply the first layer from the toes to the knee, the second layer from the toes to mid-calf, and the third from the toes to just above the gaiter region at the top of the ankle. This will achieve the higher levels of pressure needed at the ankle for good venous return. At night, the patient can easily remove the top layer when they're in bed and then reapply in the morning when they're up and about again. I recommend this study by Carolina Weller in Victoria. It's a helpful and effective solution for many people who struggle to apply compression stockings. So with the right treatment, these ulcers can be healed. It's the compression that makes all the difference, not what's applied to the ulcer. This person was treated for 2 years with minimal healing and no compression before being seen by someone who recommended compression therapy, and he was healed within 12 weeks. So in summary, leg ulcers can be slow to heal and compliance can be challenging. The key to success is good assessment. In addition to educating the patient and their family to ensure they understand what needs to be done to effectively treat their ulcer and ensure their expectations are realistic, good education is key to getting good compliance. Diabetic foot ulcers and arterial ulcers need to have the underlying issues addressed before you can get healing, and even then, this may not be possible. If the ulcer is venous, apply a suitable compression bandage that'll be acceptable and tolerable for the patient. Always remember, when it comes to venous ulcers, any compression is better than none at all. Constant monitoring to ensure the wound is progressing in the right direction, and know your bandages and how to apply them correctly. If you'd like a primary care sample pack, please email this address and we'll send one out to you. So now we're just going to have a quick game of Kahoot to recap on what we've learnt so far, and then we'll get to your questions. So if you haven't downloaded the Kahoot app, all you need to do is go to your, grab your phone and go to your app store and type in Kahoot. And once you've come up with the Kahoot, then you just need to download it onto your phone. And then you can type in, when you've done that, enter and type in your nickname. You can put in any name you like. At the end of this quiz, there are some great prizes that we'll send out to you. So what we ask is that the person who, we have a first, a second and a third prize. The first prize is actually a wound care manual by Carolyn Carville and a $50 gift voucher. So well worth having a go at this. The second prize is a $30 gift voucher and the third prize is a $20 gift voucher. So I recommend you get on board and download your Kahoot right now, and we'll go ahead with the quiz. So what I'm going to do now is just change over to the Kahoot. And the pin will be coming out to you in just a second. It's loading the game pin. So now, you can see the pin number there, and it's 6459004. Type that in, and then you should be in the Kahoot. Yeah, you've got it. Everyone's getting into it. Fantastic. Love it. Just wait for a couple of more minutes. Well done. All right. A few more. You're a very creative lot. Great names. Okay, we'll make a start. First question. How many major amputations due to non-healing diabetic foot ulcers are there per year in Australia? This was talked about in the first webinar. Okay, well done. 26, that's right. Shocking number though, isn't it? Really awful. Okay, next question. Oh, hang on, who have we got there? I don't know how they work that out when you've all only answered one question, but never mind. We'll move on to the next one. How long should you hold a burn under cool running water when applying first aid? Got to be quick with this one because I'm only giving you 20 seconds. This was again something we talked about in the first webinar. Well done. Majority of you got it right, 37. 20 minutes, that's right. Let me see how we're going. So Jelly Bean's on top. Well done, Jelly Bean. Next question, true or false? Wound closure strips are a safe, effective way to treat a skin tear in elderly patients. Again, you've got to be quick. I'm only giving you 20 seconds for this. This was also talked about in the first webinar. Well done. Majority of you got it correct. Definitely don't use wound closure strips when you're treating people with delicate skin. Let's see how you went. Jelly bean still on top. Well done. Next question. Which of the following dressings should you select to absorb exudate? Atroman, Cetuvit Plus, Hydrosorb, or Pearhaft? Oh, I'm so pleased majority of you got it right. That's fantastic. Yes, Cetuvit Plus is a really absorbent dressing. How are we going? Uh-oh, we've got a new leader. Ah, well done. Next, what are two characteristics of impaired wound healing? I've given you a bit longer for this one. Bit of reading time. This was in the second webinar. Oh, terrific. Yep, 56 of you got it right. That's great. Thank you. So high levels of MMPs and prolonged inflammatory phase will slow wound healing. And R still on top. Well done. Next one. A biofilm is often suspected if you can see it on the wound bed, there's an increase in pain, there's pus present, or delayed healing despite optimal wound management. Again, this is something from the second webinar. Yay! Well done. That's right. Delayed healing despite optimal wound management will indicate that there could be a biofilm present on the surface of the wound. Terrific. How did we go? Is R still on top? And you are. Well done. Next question. What is a positive Burger's test demonstrated by? Loss of sensation in the foot, toes becoming pale when the leg's elevated, inability to pick up a fold of skin at the base of the second toe, or pain when the leg has been elevated in bed. That's right. The toes become pale when the leg is elevated. That's correct. How did we go? R's still ahead. Well done. I think, Sheila, you've been there for a little while too. Well done. All right, now this is true or false. A short stretch compression bandage only applies compression when the person is walking. So short stretch, true or false? Come on, those last 5 people. Quick, quick, quick. True. A short stretch compression bandage is only applying pressure when they're using their calf muscle pump and walking. That's correct. So true. Well done. Now we've just got 2 poll questions at the end. Has COVID-19 reduced the number of wound dressings you do daily? And if so, by what percentage? Not at all. 25 to 50%, less than 25%, 50% to 100%. Okay, so majority have said not at all. That's interesting. And a few of you have said that it has a little bit, but not really majorly. Oh, that's interesting. Thank you for that. And the last one. Prior to this webinar, had you ever heard of Hartmann in relation to wound care products? Okay, so more of you said yes than no. Well, that's comforting to know. Thank you very much. And thank you for participating in that quiz. Let's see who the winner is. So third place was Adele. Well done, Adele. Second place, Sheila. And first place, is it going to be? Yes. Congratulations, That's great. And Granny and Kelsey were runners up. So now what we'd like you to do, please, is email that email address, which was, oh, I've forgotten it now, primary care. Hang on, let me just see if I can get it up again so that you can, and primarycare.inquiries@hartmann.info. So I'm just going to try and get it up again for you. So that's primarycare.inquiries@hartmann.info. If you could send your true names and where you'd like your prizes sent to that email address, then we'll get them out to you. Thank you very much. Now I'm going to answer the questions. I've got 3 minutes to answer your questions. Okay, so it's just these questions. How do you know if there is enough circulation to debride a wound, Penny? Well, it can be difficult, and you need to obviously get a vascular assessment, but if that's not possible, then you just watch, and it's, as we talked about last week, maintenance. The body will actually, if there is enough circulation there, and if they've got a dry, hard necrotic plug, it will start to reject that tissue and start to loosen off and push that tissue away, and you can gently start to clean that wound and support that wound and hopefully enable that wound to start progressing on. And if it becomes apparent that it is rejecting that necrotic plug, then you know that you can actually progress on, and hopefully that wound can heal with some help from you know, either some surgical intervention or some sort of activity, getting them walking around, improving their nutrition and that sort of thing. So it can be difficult. Having a vascular assessment will also help. So I hope that answers the question. How do you offload pressure for diabetic, not always access to foot clinic? So how do you achieve offloading pressure? That's a tricky one, because you really need to have a proper application of a cast to really appropriately spread the pressure on the plantar surface of the foot to ensure that they are offloading off those pressure points. So I'm sure that if you rang the high-risk foot clinic at any of your major hospitals in the area and talked to a podiatrist there, they would be able to help you with that advice. I don't feel equipped to really give you appropriate advice on that. What moisturiser would you suggest? Well, really, anything that is pH neutral moisturizer that's not going to cause the skin to dry out any further, as they're already extremely dry, the skin. We have a moisturizer, the Molicare Skin, which will provide moisture to the leg, and you need something that's going to stay there for a little while and not get absorbed up into the bandaging if you're going to put a compression bandage on over the top. So I would recommend our Molicare Skin, but of course you're best to talk to your pharmacist about what moisturisers they have available as well to get their opinion. What product do you recommend for undercast padding? Cherie, oh, you've already answered that. Yeah, we've got an undercast padding called Roltersoft, but there are certainly other undercast paddings from Smith & Nephew, and I think from a few other companies will provide undercast padding. You want something that's going to be soft. It's going to absorb the perspiration and pad out the leg. So that's sort of your aims when you're looking for a good undercast padding. Some of them can be really thin and not very padding. Our Roltersoft is really nice and soft and has quite a high level of padding, so it's quite nice. I hope that has answered all your questions, and I'd like to thank you all very much for attending all 3 webinars and participating in our quiz tonight. I hope you found them informative. We certainly enjoyed presenting them for you, and I'd like to thank the Primary Health Network for giving us this opportunity to do that. So thank you all very much, and I wish you good night. Thank you.
Thanks, Sarah, very much. A few people have had a few IT issues tonight. I will send out a link to the recording so you can all watch it. Thanks, everyone. Good night.
Thank you. Bye.